Thank you so much for having me today. I am so excited to get to talk to you about the world of intellectual disabilities. This is really a world that when I came out of my fellowship training at UCLA, I didn't know anything about. It was a black box to me. We'd send off a baby who we had a suspicion who might have a developmental problem. They'd go off, get some testing, get some therapy, go to special ed, and they wouldn't actually come back to us until like the next time they needed vaccines. Well, let me tell you that you wouldn't believe what's inside that black box. And today I'm going to be telling you a little bit about it and potentially shattering some illusions that we grew up with and maybe we don't question very much. I'm opening up that black box, and it might just seem like Pandora's box by the time we're through. So this Grand Rounds is a part of a project to improve care around the diagnosis of intellectual disability, and it's being sponsored by a grant from the Mattel Foundation to Special Olympics International. This talk is part of the physician education, along with a poster, which is a cheat sheet for your offices and break rooms. And we've also developed materials for parents that I'm going to be introducing to you later on. I'm going to be discussing the diagnostic process, give you some insights into testing, how to communicate a diagnosis in a supportive manner, and what to do when the conversations don't go well. I'm going to be going over the recent AAP guidelines on workup, talk about management, and some of the resources that are available now and for the future. First, I'd like to introduce you to Jessie. When I met Jessie, he was 2.5, 30 months. He had just moved from the Midwest with his mother, his parents, and Jessie's mother was taking care of both Jessie and his younger brother, Jerry, who had just turned 1. Jessie, when he came into my office, made a beeline for the toys, the little pop-up toys. Then he moved on to the Uno game, and he and his brother together threw up all of the Uno cards all over the place, shuffled them into a big pile. Then he went around and pushed the lawnmower around, the little pop-up lawnmower. He was clearly excited about all the toys. And when I spoke to Jessie's mother, Janice, she told me that no, he hasn't really learned a lot of words yet. And she thought maybe the move and the new baby had been really rough on him. I had observed that he actually hadn't said any words at all. So, he was doing fine in terms of growth. I was asking the mom, Janice, how things were going. And she said she was pretty overwhelmed by the 2 boys, that it was pretty hard to dress them both and to feed them both. And she was really waiting for Jessie to get out of diapers so that at least she wouldn't have to have both of them in diapers. And he was doing fine in terms of growth. And what is going through my head? Well, okay, he hasn't said a word. Clearly he has a language delay. And I think he needs a developmental evaluation. I'm not really sure of his fine motor skills, and he's really using toys that are much younger than his age. So what am I going to do? So I did what many of you might do and recommended an evaluation just to make sure he's on track and to give him the help he might need to make sure those words get flowing. Well, that didn't go over well. Janice looked very uncomfortable. She said she'd speak with her husband, and she really thought that this was due to the move. Basically, Janice's body language was, do you mean to tell me that after meeting me for 15 minutes and looking at Jessie, you're going to decide that he's not normal and needs some special classes? Did you listen to me at all? That was basically the body language that I had gotten. So I hadn't listened to her, and I actually had a lot of backtracking to do. And eventually we did decide that they would come back in 3 months, and we would see how Jessie was doing. And he did come back in 3 months with absolutely no progress. Janice and her mother and her father actually came into that visit. And we had to have the difficult discussion of let's get an evaluation now. But this time, I did ask her about her concerns. From your perspective, how are things going now? And I reflected. So it seems like the move has slowed him down. And I asked permission. Would it be okay if I shared some of my observations and some of the things that I have some concerns about? And I explored with them. One option would be to get a developmental evaluation. If we were going to do a developmental for Jessie, what are some of the good things that might come out of it? And finally, we summed up and said, so what are you thinking about doing at this point? And they actually decided on an evaluation. And as you might guess, it came back showing global developmental delays. His skills are about the 1 to 1.5 year level, and I was faced with discussing this with the family. So what do I do now? How do I have this very difficult discussion? Tell their family that Jessie has global developmental delays, and what does that mean to them now and in the future? How can we make this the best possible for both the family and the doctor, me giving the diagnosis? So first, let's build a bit of a knowledge base. Children like Jessie come into your office, like mine, all the time, and that's because developmental disability is very common. Poverty affects about 1 in 5 to 1 in 6 children, and developmental disabilities affects about 1 in 10 to 1 in 20. And intellectual disability is the most common developmental disability and is more common than all childhood cancers combined. About 6.5 million people in the US have an intellectual disability at a cost of about $20 billion annually. Every child is important, and every condition on this list is important. For children with intellectual disability, the scale is enormous. The stakes are enormous for our society. So with Jessie, how do we know whether it really is the move or whether it's something more? What does global developmental delay mean anyway? Wouldn't it be great to be able to have this great new computer-generated test? It's for first graders and tells which graduate schools they're going to qualify for. But of course we don't. Global developmental delays is considered deficits in intellectual functioning characterized by failure to meet developmental milestones in any 2 areas of development, including cognitive, motor, language, adaptive, and social. Though in practice, typically it's cognitive with at least another area, and that's usually language. By the way, did you know that OTs and PTs and speech therapists don't actually give diagnoses? They may discuss the results in a very general sense and give suggestions, but they don't give diagnoses. So when your families are coming back from those evaluations, either here at UCLA, out in the community, or the regional center, please be aware that you're likely the first person truly discussing the results and their diagnostic implications. Global developmental delay is usually used for children who are too young to participate in IQ testing, so kids under 3 to 5 years of age. Once they are able to participate, then the term should be replaced with intellectual disability. So that means that children who are 8 or 12 or 16, they're not considered to have global developmental delays, but instead they're given the term intellectual disability. So does that mean that all the children, or most, with global developmental delays are going to end up with intellectual disability? Well, no. There's actually only a moderate correlation between the cognitive scores at 2 years and intelligence quotient scores at 4 years. As you can see, it's a pretty wide range. Same goes for language. Even in children with global developmental delays, there's a wide variation in subsequent IQ scores. So if you notice, all these children have global developmental delays and are later on tested for IQ. And the largest group actually ends up in the low average IQ score. Wow, not much predictive value there, huh? So what's the difference between global developmental delays and intellectual disabilities? ID, intellectual disability, or ID, is more specific. It's deficits in intellectual functioning and deficits in adaptive functioning across conceptual, social, and practical domains, as evidenced by standardized testing. And the standardized testing is both IQ testing and adaptive testing. The conceptual domain refers to academics, so understanding things like at school, and also understanding concepts like time in the adaptive area. The social domain is learning from experience, collaborative problem solving, and following social rules. And the practical domain are things like understanding money and having skills of daily living and independence. And they have to have a manifestation across multiple environments, and of course start in the developmental period. So it feels like it's more severe than global developmental delays, and it is. So let's talk a moment about severity. It used to be that we had levels based strictly on IQ testing, so we weren't really looking at adaptive scores, and about 90% of intellectual disability was in that 55 to 69 range of IQ, and that was considered mild. About 5% moderate, and the rest are severe or profound. But this was problematic because there are people whose IQs don't match their functioning levels. So now we measure by what support is needed. People with what we used to call mild ID should be able to live independently as adults, and they have about sixth grade academics on average. And mild ID, which is now called intermittent ID with intermittent supports, is a lot of times not picked up necessarily at the very young ages, and sometimes not even to the school ages. With moderate ID, there may or may not be independent living as an adult, and there's the expectation of about second grade academics, and it's considered ID with limited supports now. And rather than severe ID, it's now ID with extensive supports, and profound ID is ID with pervasive supports. So who started all of this with IQs in the first place? Well, this guy, his name is Wilhelm Stern. He was the inventor in 1912 of IQ, or intelligence quotient. And this was started to look at the developmental age versus the chronological age. The most famous IQ test, typically we all know about the Stanford-Binet, which we still use today. For young children, though, we tend to use the WIPSI, which is the Wechsler Preschool Scales of Intelligence. And it's more child-friendly than the old matrix reasoning, like the task that we see here. And then later on, we tend to use the Wechsler Intelligence Scales for Children, or the WISC. And then as adults, the Wechsler Adult Intelligence Scales are one of the most common that's used. Really, Dr. Wechsler seems to be edging out Dr. Stanford and Binet in terms of popularity at this point. So the scores are such that 100 is average, and each 15 points, it corresponds to one standard deviation away. So 85 is one standard deviation below the mean, and 70 is two standard deviations below the mean. So thinking back to your statistics, which of course I love, so 2.1% of the population should have an IQ between 55 and 69, and 0.1% of the population has an IQ of less than 55. And this is what we see empirically as well. Though I recognize that here you might be seeing things a little differently on the wards or in the PICU, but let me just remind you that you're really seeing this at the end of a very large funnel. Here's a question for you. Are we getting smarter? About every year, our IQs get on average 3 points higher if we use the same test. Yes, this is true. It's plausible that we're getting smarter. And in fact, Dr. Flynn, who recognized the Flynn Effect, advocates for this view, even in a TED Talk if you wanted to watch it. However, this also brings up difficulties of reliability and validity in IQ testing. So how stable is IQ, especially for those in the range of intellectual disability? Should we be making this lifelong diagnosis based on the set of one IQ scores? There's typically an error of plus or minus 5 points on the standard WISC IQ test. And with that, about 6% of IQs would change up or down 10 points or more on follow-up. But is this the case for those with lower IQ? No. This recent study found that 14% of IQs changed by 10% or more over a 2-year average period. The 95% confidence interval was 25 points. Also, different IQ tests give different results. The WISC consistently scores less than the WACE by an average of 12 points. Worse, the adaptive testing scores usually from the Vineland and their by parent report are notoriously much less reliable. Wow. So perhaps you, like me, are thinking about the implications of this. Can you imagine that about 15% of the children who you diagnose with leukemia or cystic fibrosis, and 2 years later you find out that they don't actually have it? That's astounding. If there is such diagnostic instability, have we gotten the idea of intelligence wrong? Have we figured out what is intelligence? There are a lot of definitions of intelligence. Dr. Weschler calls it a global concept that involves an individual's ability to act purposefully, think rationally, and deal effectively with the environment. I personally think that's a bit of a stretch. I'm really not sure that because you have higher intelligence, you're necessarily going to think more rationally. And I have to show you my personal favorite. Intelligence is what is measured by intelligence tests. And that, of course, is by Dr. Boring, which I love. There are lots of people who don't think intelligence is one thing. One of the more popular theories of intelligence is by Howard Gardner. And he uses the concept of multiple intelligence that include logical or mathematic, musical, kinesthetic or bodily, linguistic ability, interpersonal, referring to your own inner emotions and life, and intrapersonal, reflecting the emotions of others, and naturistic, referring to seeing patterns in nature. So much more of a broad definition than what's covered in IQ tests and on the DSM-5. So we measure intelligence to determine what? Success, how we're going to problem solve in life. There are many other predictors of successful problem solving and academic work and life success than what we measure in intelligence tests. We know, for example, that emotional intelligence, the foundation of which is empathy, is key in the workplace, as is creativity. We know from many studies in our educational systems that grit or perseverance, that persistence, is more important than IQ for academic success. Behavioral and emotional control, which I certainly could use more of, has been shown to be more associated with school and employment outcomes than intellectual quotient. Finally, your character and your personal values are not measured in intelligence tests, but are critically important to how well we live our lives. Some of you might know that the man with the highest IQ is actually a bar bouncer. He was so challenged by knowing how high his IQ was that he couldn't overcome the expectations that other people had of him or that he had of himself. And he's ended up a bar bouncer. And just the opposite. People with Down syndrome consistently overlap in their abilities with the range that we call normal. And really, what is considered normal intelligence, as we saw, it's a measure of our own social context. So I hope with this brief tour, I've given you just a moment's pause to consider and think about how we categorize intelligence and what it really means. But given what we have for the DSM-5, let's talk about epidemiology. Based on the bell curve, theoretically, there should not be a difference across race, ethnicity, and across socioeconomics in IQ scores or diagnosis of ID, right? Yes, these tests, especially now, are normed on a variety of race, ethnicities, and socioeconomic status. So we should be seeing that bell curve. But if you look at the prevalence of diagnosis of intellectual disability in the US, guess who's diagnosed more often? Whites, blacks, or Hispanics? This dark blue line is the African Americans. The middle blue is the Hispanics, and the gray is the whites. What about maternal education? Again, the dark blue is less than high school, the middle blue is high school, and the gray is having more than high school education. And what about insurance coverage, which surely should have nothing to do with IQ? Look at the likelihood that if you have Medicaid, you're going to get a diagnosis of intellectual disability as compared to private insurance or uninsured. And finally, poverty. Twice as many children in poverty will be diagnosed with ID as children 200% of the poverty level or above. On the other hand, with autism, the trend is the opposite. If you're higher socioeconomic status, you are more often diagnosed with autism. This holds true for education. Higher education, yes, you get the ASD diagnosis. Similarly, if you're white, you're more likely to get the ASD diagnosis, and if you're black, as I described before, you're more likely to get the ID diagnosis. Why is there this diagnostic difference? I'm going to ask you to sit and ponder this for a few minutes and maybe sit with a little bit of discomfort. And we're going to talk about what to do once we have the diagnosis. So this is the algorithm that describes the AAP guideline for workup of ID, beginning with the history. Of course, you're going to do a family history, full physical, neurologic exam, dysmorphology. And then if you haven't come up with a cause for the ID, you're going to be going on to doing CGH and Fragile X and consider metabolic testing. Those are your first steps. Then further metabolic testing, imaging, and gene panels. The imaging is usually an MRI. And if no diagnosis is found, then at the third step, you're going to consider moving and sending on to genetics if you haven't already done so. And what's likely to be the next generation of this algorithm is that global developmental delay gene panels might be done first. Perhaps you're already doing this, or I know that some of you are doing exome sequencing. Why start with genetic testing for everybody? There's been an astounding increase in the yield from genetic studies for intellectual disability over the past 10 years, and that's primarily due to next-gen sequencing and similar advances in technology, some of which have come about here at UCLA. And this has allowed more testing and more realization of the large number of genes and really the heterogeneity, as we've discussed, in association with intellectual disability. By the way, why are we searching for the causes? This is a question I think a lot of pediatricians ask themselves. The argument against testing is that probably it may not make a difference. And, well, it's really expensive. It used to be that, only certain parents got it and they really pushed for it. But actually now, Medi-Cal is paying for CGH. And more pediatricians are ordering it for every child. There are well-documented benefits for searching for the causes of global developmental delays, and they include validation and giving information that's accurate to parents, refining treatment options and genetic co-management, and surveillance for future comorbidities, and being able to do family genetic counseling as well. So getting back to Jessie, where are we? Jessie's gone through the early intervention program. That's the Early Start program. He's had OT and speech therapy. He's been in a center-based program. That's the therapeutic preschool setting. And he's just about to turn 3. And the psychologist at the regional center says he has mild intellectual disability. And Janice comes to you and wants to know what all this means. So I'm going to start by talking about what we know about the future and how we make forecasts for the future or prognoses. And I'm going to start by sharing a letter from a future mother. This is specific to Down syndrome, but it is applicable to everybody with intellectual disability. Sorry.
cara futura mamma.
Don't be afraid.
Tu niño podrá hacer muchas cosas.
Potrà abbracciarti.
Podrá correr hacia ti.
Il pourra parler et te dire qu'il t'aime.
Il pourra aller à l'école.
Como todos.
Il pourra t'écrire si un jour elle est loin.
Because indeed, he'll be able to travel too.
Il pourra aider son père à réparer son vélo.
Podrá laborar.
Y ganar su dinero.
Avec son salaire, il pourra t'inviter à dîner.
O affittare un appartamento e andare a vivere da solo. A volte sarà difficile.
Jak těžko.
Quasi possibile.
Et c'est pas pareil pour toutes les mères.
Dear future mom,
Tuo figlio potrà essere felice. Come lo sono io.
Et tu seras heureuse aussi.
Vero, mamma? Vero, mamma?
So this brings me to tears every time I see it. I'm gonna talk to you about how to figure out who's more likely to end up with intellectual disability. And how do we know if a young child is behind, whether he or she is going to catch up? And how do we know if you have intellectual disability, how independent your life's going to be? What does that depend on, and how do we predict it? Especially if the IQ scores don't cut it, which we know. How do we ever make predictions in medicine? So we need to be foxes. Anybody ever read Super Forecasting? It's a popular book on the New York Times. And in it, Philip Tetlock talks about hedgehogs and foxes. Hedgehogs know one big thing. They have this all-encompassing worldview. They're the idealists. They discover facts that confirm what they already know to be true. Foxes know many little things. They are eclectic in their sources of information, and they're pretty nuanced in their judgments. Hedgehogs command more attention, but foxes make better forecasters. We want to be like the foxes. We want to be very self-aware of our own biases, our interpretations, our prior beliefs, our pretest probability in Bayesian terms. We need to have some humility because we're going to get it wrong many times. We live in a world of probability, not certainty. And even our most certain diagnoses are not. And we have to be like the foxes, very sensitive to the details of the individual person in front of us and how he or she and his or her life circumstances differ from the broad statistics that we depend on. We need to take that information and new information on how that child will grow and change in the future. We can't afford to have a fixed mindset about that child. We need to have a growth mindset. So, now that I have my self-awareness and I'm trying to be a fox and I've got the best information available, I have to go in and talk to Janice. How can we make this the best possible for both the family and for the doctor? Well, so how do parents generally feel about the process of getting a diagnosis? In a word, they feel awful. 60 to 90% of parents report a negative perception of the diagnostic process of intellectual disability due to having this period of uncertainty and worry. And due to not getting enough positive information and getting too much negative information about the disability, and due to a lack of understanding from the physicians who are giving the diagnosis. Parents often feel a sense of delay. And one vignette study actually showed the physicians were presented cases of children with various delays. And when the parents in the vignettes actually showed concern and insisted, even then, this didn't actually increase the probability of referral to diagnostic or treatment services. So what can we do? What do parents want? They want a meeting in private with the most knowledgeable physician. They want to be given accurate, specific, balanced, up-to-date information that's going to affect how the child is doing now. They want to be given the diagnosis in a respectful and empathetic manner without pity, without personal tragedy, and without sorrow. And they want to be able to immediately have supports and resources given to them. I don't want to put too much pressure on us, but parents actually remember every word we say. Yes, the exact words. Mothers of children with Down syndrome remembered with 82% accuracy the actual words their physicians used in giving the diagnosis, even years later. Well, this isn't too good because as pediatricians, we might be using words that parents don't understand. One study of giving genetic diagnosis showed that pediatricians used on average 18 words of jargon and 2.4 were explained. The pediatricians rated themselves after these interviews and actually thought they were doing much better with 7 words of jargon and 6 explained. So how do we do it better? There are several protocols, all with these catchy mnemonics. You might have heard of ABCDE or the 4 L's made popular by Grey's Anatomy. Nurse is one, empathy, all in caps, is one, and spikes. Spikes started as a method for delivering unexpected news in oncology, and I chose it because it actually does correlate to improved satisfaction. So you're gonna set up the interview, quiet location, enough time, having both parents there, and you're gonna think about the purpose beforehand. What do you want to happen in the meeting? You're going to assess their perception, asking what the parents understand about how their child's doing and what they understand of the testing. This is really communication 101, right? Knowing where your audience is, who they are. You're going to obtain the invitation. Can I speak with you about the results? You're going to give the knowledge and information with compassion and simplicity. You're going to address emotions with empathy. Families do need a safe environment to explore their emotions where they're not feeling judged. Emotion's really what's running through this whole process. Otherwise, it'd be easy, like pass the P's. Your child has an intellectual disability. But it just doesn't work that way. Finally, you're going to give a strategy and summary and maybe set some goals. One thing you don't want to do is to be too scripted. Like this cartoon. Of course, I'm listening to your expression of spiritual suffering. Don't you see me making eye contact, striking an open posture, leaning towards you and nodding empathetically? So I'm going to challenge you a second on how we communicate. If it's not just the words, of course, there's a lot more to it. The spoken word is about 7% of our communication. Tone of voice is 38%. And the nonverbal behaviors, like gestures, body position, location, and what we choose to wear, communicate 55%. So now I'm going to do a little bit of self-reflection on our words.
Hi, I'm John C. McGinley. I'm an ambassador for the National Down Syndrome Society, and today I'm joining up with the Special Olympics to bring you a message that's very important to me. As Dr. Cox on Scrubs, you've heard me call JD many different names over the years. Patricia, Pam, Helen, Billy, Nicole, Deb, Nancy, Kathleen, Mary, Loretta, and Grace. But one name you have never heard me use is retard or retarded. Words are powerful. Hearing the R word makes people with intellectual disabilities and those who love them feel like less valued members of humanity. That's why we're asking you to help spread the word to end the R word. Join the campaign and make your pledge. It's time to respect and value people with intellectual disabilities. It's time to end the R word.
With that in mind, let's try to unpack what the parents fear the most in getting this diagnosis. It may not be what you think. There's definitely potential extra time for learning and difficulty with that. There's concerns about not being independent in the future. There's possibly medical complications. But the biggest fear is society. Social stigma. It's clear that individuals with intellectual disability do constitute a stigmatized group who face a lot of barriers to healthcare, to schooling, employment, housing, and community participation. I bet most of us in this room, and maybe all of us, have been targets of stigma at some point in our lives for some characteristic or another. Maybe we were a different race, or maybe we were too short, or maybe we were too smart. And we're also the agents of stigma. So how does stigma work? In our thoughts, we use these shorthands to describe a group that's not us. We use stereotype. In ID, this takes the form of having lower expectations and thinking that the person's kind of more impaired than they are in reality, and thinking that they're unable to change. When we have a negative emotional reaction to the group, we have prejudice. And when these thoughts and feelings lead to behaviors, we have discrimination. We avoid. We don't want to help. We increase our distance. We stare. We talk to somebody louder or differently. And in medicine, we treat people differently, and they get different outcomes. I'm not saying this is the only reason we have different outcomes, but it's a part. For intellectual disability, this discrimination takes the form of exclusion and segregation to a group home or to a sheltered workshop, and it also takes the form of poorer medical care, less preventive care, asking others to make a decision when the patient actually has the capacity and understanding to do so, making judgments about the value and quality of somebody's life, and 4 to 6 times the preventable mortality of the rest of us. Wow. The preventable mortality. So when this group is stigmatized, there are outward forms of public stigma, and then there's the inward self-directed stigma. The self-stigma is when you're feeling shunned. It's that inner voice that says, I can't do this. And it leads to various emotions and reactions, and the biggest one is lack of self-efficacy. Think about it. To get to that self-stigma, you have to know that you're being looked at negatively, which people with intellectual disability know. You have to agree with it, and you have to apply it to yourself, and it hurts. We see this all the time with people with intellectual disability. They do know that they're being looked at and treated differently. There's also family stigma, and family stigma is stigma by association with a relative who has stigma. And that's what parents fear also. And how do we know that? Well, it's because there are no less than 24 scales that have been developed specifically on stigma and ID. Has anybody heard of the implicit bias scale? Yeah. So I'd like to invite you, if you haven't seen it or used it, to do so. It's freely available online, and it's used to test your implicit attitudes, those unconscious preferences we all have. There is one for for intellectual disability. So how does this all play out when we're giving the news of a diagnosis? Daniel Paris put it well. Too often, children with intellectual disabilities are given low expectations because it makes it easier to deal with them. What people believe about intelligence is more important than the actual intelligence. So, does anybody know Daniel Paris? He was on a reality TV show in Sweden called The Young and the Spoiled. And he actually won. But this is not the real Daniel Paris. This is actually the real Daniel Paris. This Daniel Paris, they're both called Daniel Paris, but this is the one with the quote. He was diagnosed with intellectual disability as a young child. He was in special ed throughout his schooling. He struggled and dropped out of high school. He actually went on to study psychology at USC and got a master's in counseling and education from Harvard. He now works in student advising at USC. Wow, with such a stigma around intellectual disability, when we give that diagnosis, parents have a lot going on. It's not like giving a diagnosis of a UTI or even of hypothyroidism. There's a whole social construct to go along with it. And how do we acknowledge it? Do we? Is it appropriate to? When I was preparing for this talk, I actually had to ask myself how often I discuss social stigma with parents, and I realized I could do a lot better. And I'm not alone. In a study of transcripts of pediatricians and family physicians counseling after newborn screens, only 26% used one or more empathetic behaviors. To use George Bernard Shaw's words, the problem with communication is the illusion that it's occurred. When we don't deal with the emotions, there's just something missing. So how are these parents feeling? We used to think after a diagnosis, the family had these 5 stages of grief, right? The Kubler-Ross stages, you probably are familiar with them. Denial, anger, bargaining, sadness, acceptance, right? What we know from interviews with families is that yes, the time immediately after a diagnosis is tumultuous, but with many feelings, including fear, disappointment, confusion, anger, but these are mixed with protectiveness, hope, pride, and love. Parents are often feeling more than one feeling at once. And some parents might take a while to come to terms with the diagnosis, and others feel relief that they finally have an answer, a diagnosis for what they've been telling their pediatricians about maybe for a while. We do need to be aware of the family's feelings, and to do that, we need to elicit their emotions by gently probing. How is this news making you feel? Those emotions might be guilt or anger, hopelessness or hopefulness, fears of the future. Whatever they are, we need to validate them. Many people feel scared when they get the news. Finally, we want to advise the parents that they may feel continued flux in their emotions. You might still feel worried about this when you get home, but please know that you can call me anytime. What we don't want to do is any of these. We don't want to be so inquisitive as to be creepy. How are you feeling, my dear? And we don't want to be self-validating by saying, I completely understand. Oh, I'm okay, you're okay, we're all okay. And most likely we don't understand and we can't. And even if you happen to be a parent of a similar child, I'd still caution you to make sure that there's a purpose in sharing your own experiences, because we really want the focus to be on the family. Finally, we don't want to become the dictators, and in our haste to try to be helpful and reassuring, we don't want to tell parents how to feel. This isn't something you need to worry about, or you might feel upset right now, but you'll feel better soon. I'd like to give you a set of clear do's and don'ts to help. This is going to be a poster that I hope you'll utilize in your provider rooms. We have many at the back. Here are the do's. Prepare yourself in the environment. Know the facts. Show your emotions. Meet the families where they are. Talk about abilities and give resources. And this is one resource to give. Realizing the bright future of your child with an intellectual disability. It's a guide for parents who've recently gotten the diagnosis of either global developmental delays or intellectual disability, and introduces them to the diagnosis, describes the future for them, and gives them a sense of community and also gives them a sense of resources. A lot of the quotes are from parents, and that can be extremely helpful to invite other parents into their world. So I'd like to ask you to distribute this guide as part of our project on improvement of family experiences around the diagnosis. If you could, please provide it to families, and I would be appreciative if you could help them to give us feedback. There's an insert with information on how to provide the feedback inside the booklet when you're giving it to them. So now this might seem simple, just pass them out, but I'm going to ask you in true improvement style to think a bit about your processes as you're going through and you're going back to your different clinical areas, and think about the bottlenecks you might face in getting this out. And if you do need assistance, or of course, if you need more booklets, please let us know. Also, I want to turn your attention to one other resource, the Family Resource Centers. These are federally and state mandated programs for children with all kinds of special needs and their families, and they're staffed by family members themselves. And they're specifically designed to be a clearinghouse for information and to provide a lot of support groups for different diagnoses, classes on how to get through an IEP or IHSS, and they're an incredible resource. So now for the don'ts. So don't say you're sorry. Don't try to predict the future. Don't pressure a family for a response or any decisions. Don't expect immediate grief. Don't overstate the negative outcomes, and don't overstress the dis in the disability. So what happens to families after our diagnosis? Well, 1 out of 3 children don't actually get the services for which they qualify in early intervention. I don't know if you knew that. And why is that? Here are a few reasons. Lack of family recognition of a problem. The parents don't feel like they're being respected or listened to. The families think that this is going to get better and go away. There's a lack of being able to explain the benefits of the programs. And maybe that's because you're not as familiar with the program, so I'm going to go over those in the next few minutes. And finally, trust barriers. And this actually, part of that is cultural and language barriers as well. So when things aren't going well, like with Jessie, and you're feeling some indecision and discord, here's a strategy for you. First, notice how you're feeling and take a deep breath. And then look at the interaction from the parent's and child's point of view. And then reflectively listen, affirm their emotions, and then you want to partner with the parents. You want to emphasize their own autonomy. They get to make the decisions. Reframe the discord, shift your focus, and definitely, it's not the time to argue. You actually want to apologize for any part you had in creating the discord. You want to explore the pros and cons and look for a place to compromise, to come together. How do families feel later when they're reflecting back on the diagnosis? Well, this study of parents of children with Down syndrome, done in Spanish and in English, 97% were proud of their son or daughter. 79% had a more positive outlook on life. 95% had good sibling relationships. Only 52% thought their children had significant learning difficulties. 19% had significant health problems. Families think that their children are healthy, and you should too. 5% felt embarrassed by him or her, and 4% had regret. Those children with regret, those parents of those children actually were more older adult children, and they're more likely to report complex health problems and had more learning difficulties. These are a few quotes from parents. Sometimes the people we think need the help most are actually the ones providing help to the rest of us. And I look at people with less prejudice, see everyone's potential. Keep your expectations high and fight for your children. Well, there are also more stressors. What's it like to care for a child with developmental disabilities, intellectual disabilities? Well, in many ways, it's similar to raising another child, but instead of being in diapers for 3 years, you might be changing them for 6. Instead of struggling to hold your 5-year-old's hand to cross the street, you're hanging on to your 19-year-old's. Instead of talking to your 2-year-old about not biting, you're talking to your 12-year-old. Parents are thinking about the future, whether he'll live on his own, get a job, cross the security line at the airport and no one will understand, have a family, and if he's not on his own, how is he going to be supported? That's a whole lot to think about. A whole lot of stressors. And unfortunately, there are second-level effects of the stress on children, right? The parents who are stressed interact less with their children, they're less contingent in responding to them, they're more irritable, more negative, have a more negative affect, and they tended to use more negative discipline. The children then, of the parents who are more stressed, they have more negative interactions, and so it becomes a bit of a cycle, doesn't it? So on average, parents do have higher rates of health and mental health symptoms, and the most important significant predictor of parental stress is the child's behavioral problems. But interestingly, the child's functional abilities are not predictors of parent stress. There are some protective factors that buffer these stresses: having social supports, using problem-focused coping, having a positive affect. And there have been a bunch of interventions, more coming up recently, to address the stress. Parent support groups, psychoeducation, respite, behavioral parent training, cognitive behavior therapy, and mindfulness-based stress reduction. One of our studies addressed stress through mindfulness-based stress reduction and found significant decreases in stress, parenting stress, health and mental health symptoms, and indicators that the child's maladaptive behaviors had changed as well. Isn't that amazing that we can actually change how the parents cope with stress, and then you can potentially affect the children's behaviors? So you've gotten the diagnosis, and they've gotten some early intervention, and you've talked about stress with Janice and her husband. So what are some of the therapies and supports that you need to know about to send them to? Let's do a quick tour of early intervention. What we know is that development's fluid, but there are these critical periods, and those critical periods can be influenced by purposeful practice. During these times, we tend to use OT, PT, speech therapy, early behavior therapy, and therapeutic preschool centers. And these therapies typically here in California are through the regional center, through age 3, and then the school district after that. But here's a little known secret. You can actually write orders for therapy and get it through insurance, even Medi-Cal. You don't have to rely on the school district or the regional center only. You can do it yourself. Research in early intervention is focusing on positive parenting, seeing the parents as the teachers, improving the language environment, the composition and quality of social interactions, and having individualized programs that are in inclusive settings. We know that even cognitive skills are malleable. For example, kindergartners who did not understand abstract principles were directly taught these principles through games. And not only did the children actually learn the abstract reasoning skills, they also showed substantial gains in reading and math. For motor development, we have the motor development pyramid. That younger than 1 is that pre-adaptive age, then the period from 1 to 7 is the fundamental motor skills time, and after that, you get context-specific and finally full maturation. And I want to introduce you to the Young Athletes program. It's a direct an intentional instruction program for motor skills that focuses on those foundational skills: visual tracking, walking, running, balance, catching, throwing, kicking. It's designed for kids 2 to 7 years with intellectual disabilities and delays. And it can be used in playgrounds or in classrooms for teaching by therapists, by teachers, or by volunteers. At the end of 3 months in one trial, children showed an increased motor skill of 7 to 9 months on the Peabody as compared to 3 to 5 months in the control group. Also, teachers and parents reported significant improvement in kindergarten readiness skills and social and play skills. And this is an ongoing program in our area. You can send children to it for free. You can even volunteer. We could start one here at UCLA. There's one in the park in El Segundo, and there are a bunch in schools throughout the county. Therapies don't stop at preschool, though. There are cognitive remediation interventions, augmentative communication, self-determined learning model where the children set their own goals, reading programs for even children who are nonverbal well into the school years. There are behavioral programs that go way beyond ABA, and there are social skills programs. Finally, transition age youth is an area that we're all taking a very close look at. Here at UCLA, we have the Transition Clinic, and we also have the Achievable Health Center. It's a federally qualified health center that I co-founded, takes care of children and adults with developmental disabilities, no matter the insurance status, in an inclusive setting, and you can refer children there anytime. In terms of mental health, I recommend that you look at reachacrossla.org, which has an enormous wealth of resources. And finally, in terms of vocations, we're very fortunate to have here the Pathways program for students to participate in university here at UCLA. There's also a number of work programs that the UCLA USED is focused on. And I couldn't leave this topic without mentioning a little of the policy process. And I'd invite you to look at the Surgeon General's report because there's a civil rights movement going on. The biggest policy change is that in 2019, every program, every service that we provide has to be in an inclusive setting with choices given to those with disability who are participating. There has to be a choice of an inclusive classroom, a choice of programs where the other children don't all have developmental disabilities, a choice for adults of where to live, not just in group homes, of what to eat, not just what's on the menu for the day, who to hang out with, where to go, not just walking around the mall in a group, choices of employment or vocations, not just sheltered workshops. And who knows this best? It's Chris Burke. Does anybody know who Chris Burke is? He is the character Corky Thatcher on the television series Life Goes On. Corky was the first main character in a network series with Down syndrome. His parents were told when he was born that they should put him in an institution. There's a movement that's going on in California right now, and that's self-determination. It's beyond self-advocacy and patient-centered care, and it really puts the money and the power in the hands of the people with developmental disabilities and their families. They get to decide what budgets they have and take it to the services and therapies that are right for them. Instead of typical traditional special ed, they might want to pay for a child to do an internship at a repair shop. Instead of traditional behavior, they might want to pay for an aide to go to a swim class at the Y. So where do we go from here? If you see children with disabilities and intellectual disability just a little differently, question our abilities to predict their futures and what they hold, increase your expectations just a little bit, and never, ever use the term MRCP again. That will be something. And I'm hoping you'll do a little bit more. I'm hoping you'll be a little bit more ease with giving the diagnosis and supporting families through the diagnosis and give them a better understanding of their options and their futures. And I'm hoping that one way you'll do this is to share these great materials that we've designed for you. Finally, if you want to go to the premium level, the platinum level, like the stratosphere, it might be to join the self-determination movement or volunteer. Thank you very much.